Anyway, Professor Roland has given you a beautiful overview of the ability of three-dimensional echocardiography to define the anatomy of patients with valvular heart disease. What I'd like to do over the next 10 to 15 minutes is speak about the current role of Doppler echocardiography in defining hemodynamics. I think many of us back when we were training understood that the cardiac catheterization laboratory was where all of our hemodynamics were taking place. However, with time, over the past couple decades, Doppler echocardiography has come in, and now in most institutions has actually surpassed cardiac catheterization in assessing patients, especially with valvular heart disease, in terms of hemodynamics. And I think the question that I would like to address is, now that we have these tools and have these capabilities, do we really need the cardiac catheterization laboratory anymore in 2010? So I'd like to show a couple cases, if it would ever come up on the screen, but maybe even talk about them too. And the first case that I'd like to talk about is a patient with mitral stenosis. Now, we have a 45-year-old woman, and we can maybe talk about this if you can't see the images, who comes in now because she's severely symptomatic with shortness of breath. She's got the typical findings of a diastolic rumble, and she's got the doming that you would expect in a patient with rheumatic mitral stenosis. Now, when you do her Doppler echocardiogram, one sees that the echocardiogram gives a Doppler gradient of only 5 millimeters of mercury. Yet the patient was sent because from an outside institution, cardiac catheterization revealed a mean gradient of 11 millimeters of mercury. Now, if in fact the patient has a gradient of 11 millimeters of mercury, she indeed has severe mitral stenosis and would benefit from mitral balloon valvotomy. But the Doppler says that there's only 5 millimeters of mercury, in which case this is only mild mitral stenosis, and she would not benefit from mitral balloon valvotomy. So the question that arises is, we have the cardiac catheterization. The cardiac catheterization, in fact, in the past was used all of the time to assess these patients for severity of mitral stenosis, yet now we have a discrepancy with the Doppler saying it's only mild and the catheterization saying it's severe. So we ask ourselves, well, what should we be doing at this point in time? And the answer to this, and maybe we can go back to the slides once we get them up, is in 2010, we should understand that the Doppler echocardiogram is actually the gold standard for the transmitral gradient. It is better than the gradients obtained at the time of cardiac catheterization, especially when using the pulmonary artery wedge pressure, because of the problems with reflection back and the transmission delay. And overall, if you get a transmitral gradient by Doppler, that will be the gold standard. Now, the only time that we would probably want to perform cardiac catheterization is if there is a discrepancy. And with the discrepancy, what we're talking about is a discrepancy between pulmonary pressure and transmitral gradient. And what we can do, so what we showed here, we can go back. So here is an example of a patient with a significant discrepancy, in that the mean gradient here is 5 millimeters of mercury, yet the pulmonary artery pressure is 80 millimeters of mercury by Doppler echocardiography. And if one looks at this, one would see that the pulmonary pressure indeed is far out of proportion to the transmitral gradient. This is one of the primary indications for cardiac catheterization, because in fact what you need is absolute pressures. So in a patient with mitral stenosis, one always must look at the gradient, which would correlate with the pulmonary pressure. And if in fact there is no correlation, that indeed is an indication for cardiac catheterization. And in this situation, as the patient was taken to the cath lab, the mean gradient again with 7 millimeter of mercury using direct left atrial pressure, but the left atrial pressure itself was severely elevated to near 40 millimeter of mercury, giving a pulmonary artery pressure of significant increase. And the reason that the mean left atrial pressure was significantly elevated was because there was a significant elevation in left ventricular diastolic pressure. And in this situation, by merely lowering the afterload on the left ventricle, one brings the left ventricular diastolic pressure down, pulmonary pressure down, so on and so forth. So the question is do we need the cardiac lab anymore for hemodynamics? Yes, but only when non-invasive findings are discordant. So now that we actually have some slides, let me kind of take you through another case here and give you an example on how we should be thinking about the utility of Doppler echocardiography. So in this case, we have a 63-year-old man, class 2 symptoms, heart murmur for 10 years, and the diagnosis of aortic stenosis is present. The mean gradient by Doppler echocardiography is 60 millimeters of mercury. There is a significant calcification of the aortic valve with decreased function. And the question is you've got this patient now who has findings of aortic stenosis on examination, findings of aortic stenosis on Doppler echocardiography and two-dimensional echocardiography. And the question to you is, what do you do with this patient in the cardiac catheterization laboratory? Well, in the past, many people would cross the aortic valve retrogradely, but I think it's now recognized that this is not without risk. For even though clinically apparent strokes might not occur in a large number of patients, there's been several studies which have shown that the incidence of cerebral embolic events when crossing valves retrogradely assessed prospectively by MRI scanning is greater than 20 or 25%. And some of the more recent data using the percutaneous valves has shown it's up to 70 to 80%. So crossing the valve for hemodynamics retrogradely is certainly not without risks. And we do know that the mean gradient by Doppler equals the mean gradient by cardiac catheterization in properly performed meticulous studies, especially if the mean gradient's high. The take-home message here is that when assessing a patient with aortic stenosis, the Doppler echocardiogram will not overestimate the gradient. So if in fact your mean gradient's greater than 40 millimeter of mercury by Doppler, and this correlates with your physical examination in two-dimensional echo, there is no need for hemodynamic catheterization. And in our own institution now, the percent of patients who have aortic valve assessments for aortic stenosis is less than 10%. Now, who are those 10% of patients? Well, it's a patient such as this, a 55-year-old woman sent for progressive dyspnea, evaluation of aortic stenosis. On an examination, she's got these findings of a parvus and tardus of her carotid upstroke, a late peaking murmur, and a single second heart sound. But when you do her echocardiogram, even though you might expect severe aortic stenosis, you actually get a mean gradient of over only 28 millimeter of mercury with a valve area 1.4 centimeters squared. Now, as in mitral stenosis, you have to correlate your symptoms with your physical examination with your Doppler echocardiogram. In aortic stenosis, your correlation has to be your symptoms with your examination, your gradient, and your valve area. In this case, the patient was symptomatic. The patient had severe findings of aortic stenosis on examination, yet only mild by Doppler echocardiography. So here is our discrepancy. And we all understand, but we need to apply this in clinical practice, that one of the major errors of Doppler is it needs to be parallel to the jet itself. And if it is not parallel to the jet, it can certainly underestimate the gradient. So as opposed to mitral stenosis, where we would consider our Doppler echocardiogram to be the gold standard for evaluation of gradient, in aortic stenosis, Doppler cannot overestimate the gradient, but Doppler can underestimate the gradient. And thus, in patients with aortic stenosis as opposed to mitral stenosis, the indication for a hemodynamic catheterization is when you suspect significant aortic stenosis on examination, but the gradient certainly is not there by Doppler echocardiography. I think the final thing to end up with is, because we now depend on Doppler many times, we do not take the care in the cardiac catheterization laboratory that we should. So now in 2010, if a patient comes to the cath lab for aortic stenosis to assess their gradient in aortic valve area, there is a problem and there is a major question to be answered. You need to do it to perfection. And as I tell our own fellows, we need to use simultaneous left ventricular and aortic pressure, because if one uses the femoral pressure with an aortic pressure, due to the pulse amplitude increase in the femoral or some of the pulse amplitude decrease, you can overestimate or underestimate the gradient. So in summary, we have a very, very powerful tool in Doppler echocardiography. And we use it in evaluation of all our patients with valvular heart disease. But we have to be able to know when to use it from a clinical standpoint. And I like what Professor Rowland says about the clinical indication, because we have to be able to apply both our physical examination and our clinical impression with what we find by Doppler. Know when Doppler is the gold standard, for instance, the transmitral gradient in mitral stenosis, but when further evaluation needs to be done, such as the patient with aortic stenosis. Thank you very much for your attention.